Welcome all our members of Maharashtra Ophthalmological Society and especially our young friends, our residents, and early practice ophthalmologists who have joined us today for this specialized curated webinar, which is going to be on case-based discussion, a PG program by the MOS for the MOS. And this month's theme is UVA and Retina. After the success of the UVA webinar that we had 2 weeks ago, now we are very happy to embark on this Retina case-based webinar today. We are very lucky to have my teacher and a teacher to most of us, including Dr. Santosh Agarwal sir, Dr. Pramod Bhende sir, Dr. PB sir, of course, as we know, is the chief of the Retina department at the very prestigious Shankara Netralaya. So we thank you, sir, for taking time out and joining us in spite of your very busy schedule. We are also joined by Dr. Sharad Bhomaj, sir, who is going to be our MOS faculty. We are going to have Dr. Shilpi Narnavre, who is the mentor for today's PG program, and she has been instrumental in designing it and also guiding the PGs. And of course, it is going to be moderated by our young and dynamic Dr. Anand Bhosle, who is a very well-known retina surgeon and a young surgeon from Kolhapur. We are thankful from the team MOS, especially to Dr. Sumit, who has been instrumental in coordinating this year-long PG programs. As we all know, each month we dedicate 1 month to each specialty, and we have been doing it from the first month in itself. And now we have come to this month, which is for retina and uvea. Friends, we all know that during residency, many of us don't get full exposure to retina and UV as subspecialties because many medical colleges do not have a full-fledged retina department. So this is a great avenue, a great chance for all our young stars, all our young residents to learn from the pioneers, from the stalwarts, both the exam-oriented tips as well as the practical tips about retina. We are also joined by our MOS team, which is Dr. Atulji Kadane, who is the honorary secretary, Dr. Mandarji Paranzape sir, who is honorary treasurer, and also Dr. Aditi Vatve, who is the secretary of the scientific committee. So before we go further, now I would like to welcome our guiding force, our strongest support, our president, Honorable Dr. Santosh Agarwal sir, to please kindly give his presidential address. Over to you, sir.
Thank you, Vardhaman, for your kind words. Respected seniors, Dr. Pramod Bhende sir, our beloved teacher from Shankar Netralaya, Dr. Sharad Bhomaj, Dr. Shilpi, Dr. Anand Bhosle, and our PG students, Sanmitra Dhar, Dr. Prerna Jogdhane, and my MOS team, Dr. Vardhaman, Aditi, Atul, Mandar, Dr. Sumit, who is instrumental for this webinar, and all my dear friends. Very good evening to everyone. On behalf of MOS, I welcome you all to this distinguished webinar, wherein today we are going to have case presentations by our own PGs on different retinal conditions, followed by the Viva, which will be taken by their teachers, and later on, in continuation to that, our acclaimed faculties will exude their views, comments, and provide invaluable tips which would not only helpful to our residents but also to our esteemed members as well. I thank Dr. Vardhaman, Aditi, and especially Dr. Sumit for crafting such a wonderful webinar today. I appeal to all PGs and our members to please attend such webinars to know the basics and the preferred practice pattern while dealing with varied eye diseases. Thanks to all faculties, my MOS team, as well as everybody who has joined this webinar. Thank you, everyone. I wish all the best to our resident doctors for their future life. Today's my quote of the day is, it's actually written for my daughter. She's in MBBS. Make your day nicer, fruitful, and enthusiastic. Always embrace the good things each day and leave behind the bad. Always start your day with positivity and end with positivity. Make the atmosphere humorous and vibrant. Let's smile and make others smile as well. So thank you very much for your kind attention. Thank you.
Thank you very much, sir. I think we always look forward to your quote that inspires everyone. So before further ado, I think Dr. PB sir is probably wants to speak something. Yes.
Santosh has said there's a vibe. PG का tension बढ़ जाएगा यार. It's a panel discussion, not vibe. I tell them to take it lightly. So
Yeah.
Yes. Thank you so much, sir. So without further ado, now I would like to hand over the whole organization to Dr. Sumit, who has been the main coordinator. So over to you, Sumit.
Thank you so much, sir. Very good evening, everyone. And I would like to start with thanking our MOS team, Santosh sir, Atul sir, Vardhaman sir, Aditi ma'am, Mandar sir, for giving this great platform to all lower PGs of Maharashtra. And we are covering almost each and every college zone-wise. And the PGs are very happy that they are getting opportunity to present in front of such senior faculty. So today we have a retina session, and retina, as we all know, is very important topic. And to guide us, we have Dr. Pramod Bhinde sir. He doesn't need any introduction. He's mentor to mentors, and he is a great grand referral center of all over India. Wherever the cases are unsolvable, it goes to Dr. Pramod Bhinde sir at Shankar Netra Lab. Thank you, sir, for being here. We have our mentor, Dr. Sharad Bhumad sir. Sir is doing very high volume work of retina trauma in Miraj in Shanti Saroj Netralaya. He has more than 23 years of experience in retina as a subspecialty. Sir has his own fellows and PGs, and he is very keen in teaching. And thank you, Bhumad sir, for taking out time and being here with MOS for the PG teaching program. Our mentor for today is Dr. Shilpi ma'am. Shilpi ma'am again is very popular among PGs. She is doing her brain teasers quiz since last 4 years, and ma'am is a great retina surgeon working in Nagpur. Thank you, Shilpi ma'am, for mentoring and providing your postgraduates for this program. We also have Dr. Purvasha Narang ma'am. Ma'am is faculty from AIMS Nagpur. Though she is a cornea surgeon, she is a coordinator for all the PG teaching programs. And thank you, Purvasha ma'am, again for mentoring your student even for the retina cases. Our moderator today is Dr. Anand Bhosle. He is a dear friend working as a anterior segment plus posterior segment surgeon in Kolhapur, and he will be the moderating whole show today. And our celebrities for today is actually Dr. Prerna and Dr. Samarpita, who will be presenting their cases. So I'll hand it over to Dr. Anand, and Dr. Prerna will be starting her case. Dr. Prerna, meanwhile, you can share your screen. Anand, over to you.
Thank you, Sumit, and everyone. Dr. Prerna, please share your slide. You can start presenting.
So there will be a case presentation by Dr. Prerna, followed by there will be questions, Viva OC kind of a thing by Dr. Shilpi to her, followed by Dr. Anand discussing the case further with the panelist. Prerna, you can start. We can see your screen.
Good evening, one and all. First of all, I would like to thank all the committee member of the MOS for giving me this opportunity, and also my teacher and my mentor for guiding us. Myself, Dr. Prerna Chakdhane, DNB second year resident from Sarakshi Netralaya, Nagpur. Now I would like to start my case. "63 years female housewife residing at Nagpur came with a chief complaint of diminution of vision in right eye since 6 months. Patient was apparently all right 6 months back when she started complaining of diminution of vision in right eye, which was gradual in onset, progressive in nature, and painless. Patient also started complaining of distorted of vision since 6 months. In ocular history, she was using spectacles since 20 years. She has underwent some eye surgeries in right eye 6 years back and 5 years back in left eye for diminution of vision. She has no history of flashes of light, no history of redness and pain, no history of any ocular trauma, no history of any topical medication and any ocular laser treatment. Systemic illness was not present. She was systemically nil. No any significant family and personal history. Patient was well oriented to time, place, and person, and all vitals are stable. Systemic examination was within normal limit. On torchlight examination, patient was orthopedic, head position was normal, facial symmetry was present, ocular movement in both eyes was full, free, and painless. In right eye, in uncorrected visual acuity was 660, which did not improve with the pinhole. In left eye, uncorrected visual acuity was 612, which improved to 66 with -1 diopter spherical and -2 at 60-degree diopters cylindrical. Intraocular pressure by Goldman applanation tonometry was 14 mm Hg in both eyes. Anterior segment examination by slit lamp in both eyes shows normal lids and conjunctiva, clear cornea, white anterior chamber. Iris color pattern was normal. Pupil revealed normal direct concentric and direct and concentric light reflex present. After pharmacological dilatation, 8 mm was the diameter of the pupil, and both eyes revealed pseudophakia with iolene back and well centered. In right eye, Wadsky-Allen test shows was positive, which is revealed by break in the slit limb at the macula, and it was a negative in the left eye. Fundus examination in both eyes revealed clear media, normal disc, that is CD ratio of 0.4, normal. NRR was a healthy, blood vessels was normal. In right eye, macula revealed absent foveal reflex with a central 1 mm red spot with yellowish base at the yellowish base and yellowish to grayish ring surrounded by it, suggestive of macular hole, while the left eye foveal reflex was positive and the peripheral retina was on. So my provisional diagnosis is both eyes pseudophakia with right eye macular hole.
Excellent presentation, Dr. Prerna. So can you show any other investigations if you have done apart from this?
Sir, we have done OCT in both eyes, that is right and left eye.
Can you please describe the right eye OCT?
So in right eye vitro-retinal interface revealed PVD, and also there is a break in the break in the continuity of the internal as well as the outer retinal layer, suggestive of macular hole. Surrounding the macular hole, there is an intraretinal cyst, and the diameter of the base is 1141 micron. So after OCT, my final diagnosis is both eye pseudophakia with right eye stage 4 full thickness macular hole.
Can we go ahead with questions by Dr. Shilpi, please?
Yes, sir. Good evening, everyone. So thank you for this opportunity. Dr. Prerna, I would like to ask, can you just elaborate what is Wadsky-Allen test?
Yes, ma'am. Ma'am, Wadsky-Allen test is a simple diagnostic test it is done to find out whether there is macular hole or there. It is done in a slit lamp biomicroscopy with 78D, in which we project a vertical slit beam in the macular region. So that the patient, in case of positive test, patient revealed there is a break in the continuity of the vertical beam. Also, we can appreciate this on the slit lamp.
Okay, you see a discontinuity in the line.
Yes, sir. Yes, ma'am.
Okay, and okay, in your diagnosis, it is stage 4 full thickness macular hole. So, what are the various stages of macular hole?
Ma'am, according to the gas classification, there are 4 stages. In stage 1, it is impending macular hole. In stage 1A, there is a loss of foveal depression with central yellow spot, that is a foveal pseudocyst. In stage 1B, there is a loss of foveal depression along with the central yellow ring. In stage 2, and there is macular diameter is less than 400 micron, in which there is a foveal dehiscence. In stage 3, the macular diameter is more than 400 micron, but there is no complete PVD or any Wiese ring is appreciated. While in stage 4, macular diameter is also more than 400 micron, but there is a complete PVD associated with the Wiese ring.
Good. You did the Amsler test in your patient?
Ma'am, yes, we did, but
was not recorded.
But I will.
Okay. Okay. So, what is Amsler chart basically?
Ma'am, Amsler chart is done to it is just a grade of multiple square. Each square is a 0.5 centimeter square. Each square is a 0.5 centimeter of a total size of 10 by 10 centimeter square. Each square is consist of a 1 degree visual field. It is done to check the central 10-degree visual field from the center point of fixation. We ask the patient to ask the patient to focus on the central point of fixation and note whether there is any break in the continuity of the line, or whether there is any surrounding any scotoma or the missing of the lines. And Amsler grid are of 7 types. Mostly we use the chart one, in which the grade is of white color and background is of black color. It is used for any macular diseases, also any optic nerve lesions. For the also prognosis we can do from this test.
One thing you will have to say that we need to close one eye while doing the Amsler chart. Okay. So the last question is, what is the principle of management? What you did in this case, basically?
Ma'am, we did the pars plana vitrectomy plus ILM peel with inverted flap plus PFCL plus FG and C3F as a tamponade. Main principle behind the surgery is to reveal the vitromacular traction, so that the macular hole is closed, and also the ILM peel inverted flap is done to so that it will not proliferate the cellular proliferation and to decrease the vitromacular traction basically.
The principle is to just relieve the traction by posterior vitreous detachment. Inverted flap is done just to stuff the ILM, and that is controversial in many cases. It is not to prevent the reproliferation. Instead, it is been said that with the inverted flap technique, in many cases, you can get proliferation over that remaining ILM. Okay. So,
Thank you.
Over to answer.
Dr. Sumit, should we request our esteemed faculty to ask any questions, or should we go ahead with the next case? Bhumat sir or Bende sir, would you like to ask any questions to the candidate?
Basically, not a question. What I would suggest is otherwise doesn't make difference, but you are talking about postgraduate presenting cases and Shilpis taking whatever. They have to appear for examination. That's what we look at it. And first and most important thing is avoid abbreviations while presenting the case. Something like EOM, presenting like NRR. We understand what does that mean. Retina is attached, not retina is on or off, attached or detached. So because see, we assume that all of us understand all these things, but tomorrow examiner, whoever is examiner, can object for that, and then this is a scenario students get really tense because examiner goes somewhere else. Then you, and whatever preparation you would have done, you start, once you are tense, your common sense doesn't work, and then you are in trouble. So basically, definitely avoid abbreviations while presenting the case. Otherwise, very well presented case. Okay. I mean, congratulations to her, Prerna.
Thank you, sir.
If everyone is okay, can we go to the next presentation, please?
In this case, they have mentioned stage 4 macular hole. Hello?
Yes, sir, you're audible, please.
Yes, sir.
Yeah. So basically, one is based on the size of the hole, and then is the status of the PVD. So in this particular case, the OCT shows attachment of the hyaloid to the optic nerve. So based on that hyaloid detachment classification, it may not be the stage 4 because the hyaloid is still attached to the optic nerve head. But based on the size of the macular hole, it is stage 4. There are two kind of stagings which are used for macular hole: absolute size and then the status of the PVD.
Yes.
I agree to sir's point of view. If you can go back to the OCT, please.
Yes, sir.
And generally we use the minimum linear diameter and not actually the base diameter. So for the size of the macular hole. So this macular hole is pretty large, but generally we measure the minimum linear diameter and not the base diameter for size of the macular hole.
So you can see a line coming from the top, a white line, which is going and attaching to the temporal margin of optic disc. That is the vitreous attachment. That is what sir was trying to mention, that it is not complete posterior detachment, but the vitreous is still attached to the optic disc. So technically it could be a stage 3 macular hole, depending upon the one of the classifications which sir mentioned.
But you can give her benefit of doubt, because from macular hole, vitreous is separated. So
Yes. No, just an observation.
no, it is observation, and need to know while describing the OCT, she has to
Yes.
describe that one. Very, very important
Yes.
point,
Yeah.
Dr. Sharad.
Yeah. You can see in the left eye, you can see the hyaloid detached, but still we cannot see the attachment to the optic nerve head.
Yes.
So even in the other eye, it appears to be attached to the optic nerve head. So optic nerve head detachment is the last thing which occurs in the PVD. So that is very well nicely seen on the OCT. Sometimes you can see some vitreous opacity, but on the OCT you can see the attachment on the optic nerve head. So that is the thing.
Patient doesn't have glaucoma, right? This right
No.
eye looks deep actually.
Everyone is okay. Can we go to the next presentation?
Yes.
You can stop sharing your screen and let Samarpita to share her screen.
Good evening to my teachers and esteemed judges present here. First of all, I would like to thank for giving this opportunity to me to present in such a great platform, and also to my mentors for helping me with this case. I am Dr. Samarpita Dhar, a second year junior resident at AIMS Nagpur, and today I am going to present a case. A 50-year-old male resident of Nagpur presented to the ophthalmology OPD of AIMS Nagpur with the chief complaints of floaters in his left eye since 6 months, profound diminution of vision in his right eye since 2 months, floaters and flashes of light in his right eye since 2 months. The history of present illness revealed that the patient was apparently all right 6 months back when he started experiencing floaters in his left eye since 2 months, and in his right eye he had the complaints of profound diminution of vision in his right eye since 2 months, which was sudden in onset, painless in nature, stationary and non-progressive in course. It was also associated with intermittent episodes of floaters and flashes of light and was not associated with any diurnal variations. There was no history of any ocular trauma or thick spectacles use, no history of any ocular surgery, no history of fever or any other infections. The past history was insignificant and there was no history of any similar complaints in the past. The patient was a known case of systemic hypertension and type 2 diabetes mellitus since 2 years on regular oral medications, and there was no history of any other systemic illnesses. The patient took mixed diet and followed a normal sleep cycle. There was no history of tobacco, alcohol, or any other addictions. The family history, medical and surgical history were insignificant. On general examination, the patient was of average build and moderate nutrition and was conscious, cooperative, and coherent to time, place, and person. The vitals were all stable, and the CNS, CVS, respiratory, and abdominal examinations were within normal limits. On ocular examination, the facial symmetry was maintained, the head posture was normal, the eyeballs were aligned, and the extraocular movements were full, free, and painless in all cases. The visual acuity of the right eye revealed hand movement close to face, with projection of rays absent superiorly, nasally, and inferiorly, and present only temporally. The patient did not accept any refraction, and the near vision could not be assessed because of his profound diminution of vision. The intraocular pressure in his right eye was 10 millimeter of mercury. In the left eye, the visual acuity unaided was 6 parts, which improved to 6 on giving plus 0.5 diopter sphere, and the near vision and intraocular pressures were within normal limit. The anterior segment findings of the right eye was within normal limit except for the pupil, which showed a relative afferent pupillary except for the consensual light reflex, which was absent. On indirect ophthalmoscopy of the right eye, after full dilatation, the media was found to be clear and the disc was of circular shape, average sized, with a cup disc ratio of 0.3:1 with healthy neuroretinal rim and clear margins. The vessels emanating from the disc had a normal arteriovenous ratio but were found to be detached because of retinal detachment, which was denoted here as blue shades, and it was found to extend from 1 clock hour to 6 clock hour, and two horseshoe shaped tears, one of which was operculated, were found here denoted as red with blue margins, and two lattice degenerations were also denoted, which are denoted here as blue hatched lines. The macula was detached, and the attached retina showed multiple tessellations. This is the fundus montage of the right eye, which shows multiple lattice degenerations with horseshoe-shaped tears with rolled edges and detached retina, here denoted with arrows. On the indirect ophthalmoscopic of the left eye after full dilatation, a clear media was revealed with a circular average-sized disc of cup disc ratio 0.3:1 with healthy neuroretinal rim and clear margins. The blood vessels emanating from the disc had a arteriovenous ratio maintained, and the macula was attached with the foveal reflex present. The retina was attached throughout but was highly tessellated, and multiple lattice degenerations were observed extending from 10 clock hours to 6 clock hours, one of which was with a hole. This is a fundus montage of the left eye showing multiple pigmented lattice degenerations in the periphery, and one of which showed a hole as denoted in this picture. Based on the history and examination, a diagnosis was made of right eye subtotal rhegmatogenous retinal detachment with horseshoe tears with pigmented lattice degenerations with proliferative vitreoretinopathy grade B with macula with phakic lens, and left eye myopic fundus with pigmented lattice degenerations with phakic lens. This diagnosis was based on the history of sudden, painless, profound diminution of vision with floaters and flashes in right eye, and the fundus findings of right eye showing a detached retina with horseshoe tears, and myopic fundus findings in both eyes showing lattice degenerations. Thank you.
Dr. Silpi, please go ahead with questions.
Okay, sir. First of all, I would like to ask Dr. Samprita, it was non-progressive loss of vision?
Yes, ma'am. It was non-progressive.
Because usually, if it is a duration of 2 months, it should not, retinal detachment, it will increase. So it is progressive loss of vision. Okay. Okay. Now, please let me know what is the blood supply of the retina.
Yes, ma'am. Ma'am, the outer 4 retinal layers, which is the retinal pigment epithelium, the layer of rods and cones, and also the outer nuclear and outer plexiform layer were supplied by the choriocapillaries, and the rest inner 6 layers are supplied by the central retinal artery.
Okay. And in your case, there were retinal holes, horseshoe tears. So how will you differentiate between retinal hole, horseshoe tear, and what is giant retinal tear?
Yes, ma'am. Ma'am, retinal holes are small, oval or round-shaped structures which are found because of chronic atrophy of the pigmentary retina and have less predisposition to form retinal detachment, whereas horseshoe-shaped tears are full thickness full thickness retinal breaks, which are of typically horseshoe shaped, and the apex of it is detached from it because of the anterior vitreous traction, and the base is attached, and most commonly it is found in areas with lattice degenerations. And similarly, giant retinal tears are retinal tears which involve more than one quadrant, that is more than 90 degrees of the circumference of the globe.
Okay. We call it at 3 clock hours. Another thing is in horseshoe tear, the flap is always posteriorly. Okay.
Yes,
How
ma'am.
do you differentiate between, because your case is 2 months old, is the
Yes, ma'am.
history. So how will you differentiate between whether it is an acute retinal detachment or a chronic retinal detachment? What are the differentiating features between the two?
Yes, ma'am. Ma'am, in chronic retinal detachment, when we observe the fundus on indirect ophthalmoscopy, we can find a demarcation line, and the retina will be atrophic and thinned out. And in very prolonged retinal detachment, like more than, we can also find intraretinal cysts, and in less chronic cases, we can also find proliferative vitreoretinopathy changes, ma'am. Whereas in fresh retinal detachment, we will find RAPD, anterior uveitic features can be there, and also a Schaffer sign, which is tobacco dusting, which is found where the RPE pigment cells in the anterior vitreous will be found in fresh retinal or acute retinal detachments.
And what are the all predisposing factors to cause retinal detachment and which needs treatment?
Yes, ma'am. Ma'am, predisposing factors are lattice degenerations, snail track degeneration, white without pressure, the retinoschisis. This, ma'am, and most commonly lattice degenerations. It will prophylactically they will require a barrage laser so as to prevent the development of retinal detachment.
We do prophylactic barrage laser in every case of lattice degeneration.
Every case, usually post in lattice degenerations. In every case, ma'am. I will read about it in which cases, ma'am.
And you forgot to mention about the most important point, that is horseshoe tear.
Yes, ma'am.
That needs
Horseshoe
to.
tears.
Okay. In this case, will you do the laser in the other eye or not?
Yes, ma'am.
Yes. Acha, what is vitreous base and what are the normal attachments?
Ma'am, a vitreous space is the region where the vitreous is most strongly adhered, and it is present 1.5 to 2 mm anterior to the ora serrata, extending to almost 1 to 3 mm posterior to the ora serrata, and has the strongest attachment. Other than that, the vitreous is also attached on the optic disc, on the macula, and in the peripheral vasculature.
Which vessels?
Peripheral, the vortex veins, ma'am.
Exactly. Great. Nice presentation.
Thank you, ma'am.
Over to you, sir. Anand, sir.
Can we request the esteemed faculty to ask any questions pertinent to this case, Mohammed sir, Bendy sir?
So basically, what management was done for this case?
Sir, for this case, right eye passed in a vitrectomy with endo laser, and for internal tamponade, silicone was injected into the eye, sir.
Okay.
And
So
after
encircling
4
band
months,
was put. Encircling band was placed.
no, sir.
Okay. What is the age of this patient?
50, sir.
50. Okay. So clear phakic lens and young patient, multiple lattices, multiple horseshoe tears, Definitely, we should consider putting the encircling band in such patients. Though there is a trend to not put band in many patients, but especially who have got multiple lattice degenerations or degenerations in more than two quadrants, they will definitely, and young patients, they will definitely benefit from putting the encircling band. And what treatment was done for the other eye?
Other eye underwent prophylactic barrage laser, sir.
So it appeared to be quite posterior, the lattices. And
Yes.
it has to be based on the surgeon's discretion. So majority of the surgeons may not opt for this prophylactic laser in the kind of lattices which you showed. Very large multiple lattices. Some of them were very posterior. So maybe not all surgeons will prefer to do laser barrage for such lattices and wait for the natural evolution. So what is the cause of the detachment in this patient? It is the lattice, or what is the cause of detachment?
Previously, because the patient's fundus revealed myopic fundus changes and multiple lattice degenerations were also there. So could be that because of retinal thinning, a horseshoe tear that developed, it led to formation of accumulation of subretinal fluid there and hematogenous retinal detachment. Sir.
The commonest cause for development of detachment in lattice degeneration is the onset of PVD. So once the PVD occurs, that is how the horseshoe tears form at the posterior margins of the lattice degenerations because they are strong areas of vitreoretinal adhesion. So by on their own, these lattices are not predisposing to the detachment unless they have got multiple round holes which are full thickness and in young patients. So only lattices without holes, they do not predispose to detachment on their own unless the patient develops PVD. So acute PVD, when it develops, the horseshoe tears form along the posterior edges of the lattices. And that is the reason why this patient has developed a detachment. So it is the acute PVD which is caused the detachment. Because there are no holes within the lattices in these patients. In the patients which you showed. Yeah. Yeah, Pramod sir.
I think what you have covered up, I think, well, it's easy for all of us to ask questions. But I think for considering a postgraduate second year, so we all sitting as a retina people here. But I think for her as a second year PG student, she has presented extremely well, and really let me congratulate her.
Thank you.
So,
we cannot take this opportunity to ask as a junior consultant in retina, ask my doubts to the esteemed faculty so that we have a bit extended. Can I share my screen if everything?
Yeah, just before that, I just wanted to go through few of see basic again. I'm just going back. I'm reminding myself as my PG days. We'll come to your thing, but before that, certain basic things again. When again terminology here. She used the word extraocular movement. It's always extraocular muscle or use ocular movement. It cannot be extraocular movement. Okay. So reflexly we use the word. So please use the word ocular movement. It's like a full everything, no restriction, nothing. All those things, that's fine, everything, but not the term. Also, fundus drawing you draw nowadays. That art is we are missing that art because we have wide angle visualization system, wide angle cameras. But when you want to draw a fundus, particularly larger drawing, probably I was expecting Shilpi would ask, what are the landmarks you see on a, that is also called as Macular chart. For the drawing sheet, what you large fundus drawing sheet, where is the equator, where is the aura, where is pars plana. So that's what Dr. Sharath, looking at the drawing only, he said, like, say, innermost circle, equator, and your lattices almost near equator. And probably, yes, I agree with him. This type of scenario, so many lattices doing laser itself can have its own set of side effects and complications. And I would have observed in this situation, though patient had other eye detachment. So that drawing where the lattices where, I think that is more important. Also, when you draw this fundus drawing, if you look at your drawing both the eyes, the purpose we draw the blood vessels basically when you operate, particularly when you are planning buccal, your blood vessel act as something like your GPS. Nowadays, GPS, what everybody understands. Basically, intraoperatively, you can have a lot of other difficulties. Cornea become hazy, pupil become small, some hemorrhages, hypopenia, you are wearing gloves, media, all those factors like a compromising your visualization. And when you have a fundus drawing, it acts as a roadmap for you. So those blood vessels lead you to where your lesions are when you're planning to treat. So just drawing a 2-4 lines around the disc doesn't serve any purpose. So when you want to make a large drawing, please try and trace those vessels from disc to the aura, ideally, but at least as far anteriorly as possible. Always do that. And particularly when you have a specific lesion, whether it is lattice, whether it is tear or a break, or whether you have some pigmentation, hemorrhages. So those particularly vessels leading to those lesions, we should be drawing so that intraoperatively, and even if you have a compromised view, at least you know, Allah, I have to trace this vessel, I have to go along this vessel, and that is where my lesion is. That's the whole purpose of having those large drawings. Okay, so when you draw, please do that. Yeah,
Yes,
Dr.
sir.
Anand, please go ahead. No, otherwise you have presented extremely well.
Thank you, sir.
Let me congratulate your mentors also. अच्छे से areas करवा दिया है उन्होंने तुमसे. Good.
Thank you, sir.
Yeah, please, Dr. Anand.
Are my slides visible?
Yes, yes.
So just a few this thing. This is a 46-year-old female incidentally presented into the clinic with this kind of picture, and she had come for glasses, and this was the picture on clinical exam, and a fundus picture, and this was the autofluorescence. And she was referred actually by an anterior segment as a case of detachment. There is a very tiny hole anteriorly on the top. Apart from that, there is no any positive clinical finding, and probably there is a watershed line which is getting formed. So along this margin. So what would be the take of esteemed faculty on this, and how should we counsel the patient?
Sharad, you would like to take it?
Yeah, I would like to go for segmental buccal for this patient. Superior temporal quadrant, there is a small hole, that's what you said.
Yes, sir.
Yes. So I would just do a segmental buccal for this patient.
Okay, sir.
Lot of demarcation lines have been formed. We don't know for how long it is. Possibly it may not progress also. But definitely I would avoid intraocular procedures like a vitrectomy and other things. So the choice for us is observation, laser barrage, and segmental buckling.
Bende, sir, your opinion, please.
Yeah, this peripheral retina, what like anterior to the demarcation line, I'm not able to differentiate whether it's really detached or attached or just demarcation line. Yeah.
It is like this, sir. Anterior to the demarcation line, it is detached, but posterior to it, it is well attached.
Yeah, then I agree. I'll go with what Sharad said. Probably segmental buccal is the best option here. The reason is, though it is a little bit peripheral, probably laser can be done, but probably because pigmentation already is there, so maybe you may not be able to get laser burn if there is some fluid there, particularly inferior part of the brain, if there is a trickling fluid. That is one part. And secondly, just marginally crossing the midline, rather not midline, equatorial area. So some amount of field defect probably will be there if you check for a field. both eyes open, she may not complain, but probably some amount of field defect will be there. So yes, I would agree, Sharad, I would go for a segmental buccal with that.
And sir, for the choice of the buckle, any particular this thing would you like 276 or depending upon the marking during the surgery?
Always depending upon marking. Always.
And a quick case 2. So this young gentleman, type 1 diabetic, presented to us with right eye rubeosis iridis and 60 pressures with corneal edema, and left eye is on the Excellent chart is reading 6.6. And when he comes, we show this picture to him and we tell them that he needs laser, he needs further treatment. He says, Doctor, I'm perfectly reading all the lines on your chart. So how would you counsel and what would you will be your next this thing to go? Unfortunately, I don't have the OCD of this, but we can very well see here beyond the arcades, it is a detached retina. And the central part is attached with well-maintained foveal contour.
OCT you didn't do, or you are not have only?
No, sir, I did do, but it was not transferred to my this thing system today.
No, fair enough. But now, what was there in OCT? With the fovea is either a side of the fovea retina is pulled up, detached, and just fovea can be attached.
So there is a minimal contracture of the fovea towards the disc, very minimal. But rest of the fovea is very well attached. That's why you see reading very well. 6.6.
How old patient is?
Patient is 21-year-old.
21.
Yes, sir. He's diabetic since 15 years. Type 1.
Probably. It's one of the most difficult cases, I would say. Most difficult for decision making as well. Because these are the cases who end up you in a nothing to gain, everything to lose. So probably now you have to take a call here. Look at the previous history. Technically, given option, just you show this case, yes, we should be operating this way. That's one way of looking at it. But look at the vascularity, look at the fibrosis all around, pulled up everything. Technically, for a surgery case is extremely difficult. It's one of the toughest surgical case, I would say. And even if everything goes well, still he will have some compromised vision. Probably these are the cases you may not be able to manage without creating iatrogenic break. And that means your oil and other thing. And the moment you put oil, subsequently cataract. So, but yes, you can convince it, you go ahead with surgery, everything goes well. Probably some compromised vision will be there, but that he will maintain vision. But the other flip side of it is because high risk of complication, lot of dissection inside, and if things won't go well, he is going to lose that existing vision at all. So particularly having a 6.6 case, generally 6.6 vision, another eye is lost. So this is what is open question directly patient or and his attendant going to take a call. But over a period of time, last few months or suppose like 6 months, 8 months, year, patient says my vision, because now only one eye, other eye is lost. So probably he will be aware of if there is a progressive loss of vision. Though having a significant vascularity, vessels are tortuous, dilated, so disease is definitely active. And if you leave it, he's going to lose that. But if he says last 6 months, 8 months, 1 year, I'm not having vision is maintained and I'm okay, and particularly his diabetes is very much under control, then give an option of him that you can continue the way you are. Though you know, as a surgeon, eventually he will lose, and because you say 21-year-old, so there's a more likelihood that over a period of time he is going to lose this vision. But if he says, okay, as long as as rightly you mentioned, I don't have problem, my vision is good, why I should undergo surgery? And that situation is a difficult scenario because now you touch this eye, and if something goes wrong, he is going to blame for it. So have a close watch. As a first thing I said is like I would like to operate on this, but you have to be in ground reality. You have to take into consideration that yes, I would like to tell him I would like to operate on you, give an option, because eventually you will lose. But if you feel you are stable, you feel your vision is okay, you think you are managing your day-to-day activity, yes, please continue. Ensure your parameters, systemic parameters strictly under control. But the moment you feel sight is saying that, yes, vision is going down now, please come, we'll take you for surgery. But yes, also remember, if your vision goes down, macula detaches, and you operate that stage, even if surgery is successful, outcome is not going to be as good as what you're going to have. Extremely difficult to convince this type of patient, and also there is a high risk of losing these eyes intraoperatively. And again, being a young diabetic, risk of very high risk of intraoperative bleeding, high risk even though with anti-VEGF, high risk of post-operative recurrent vitreous hemorrhage. That risk also is very, very high. I hope I answered. Sharad, would like to add this something?
Yeah, it's a very difficult case because he's one-eyed, and the kind of vascularity he has got. When we touch these patients, definitely they will lose at least 2 lines of Snellen's visual acuity because of iatrogenic complications intraoperatively, such kind of cases. So I will advise close follow-up serial observation. And the moment the OCT is showing traction, which is worsening, or the patient suggests that the things are worsening, at that point of time, we take him up for surgery.
Dr. Shilpi, what would you do about this case?
Sir, as already discussed, in these cases, we should leave it to the patient because we all know operating such patients, we are going to lose some vision. And if patient is not ready and he's saying he's seeing everything, better he should approach us and say yes, now he want to get operated, else he will blame you.
Yeah, exactly. So at least a poor vision you operate, he was not going to blame you. Otherwise, he's going to curse the rest of your life.
And sometimes what happens that these patients, they maintain good vision for many months and many years. So even if he loses vision, let him lose with the natural history rather than losing suddenly because of the surgery. It's a very difficult case, one-eyed patient and such florid proliferations.
Then he will be behind you throughout the years then, always.
I thought of doing some peripheral laser, but there is a very thin strip around anterior.
I don't think it is advisable to do laser in such patients. We have to do directly anti-VEGF assisted surgery only.
Yeah.
I think laser will cause worsening of the traction. So I will not touch the.
So no laser, no anti-vision. Anti-vision definitely no, unless you are taking for surgery. You are working in the scenario because probably there is no place to laser the way retina is up to periphery.
Yes, sir. Very angry looking vessels and extending up beyond the equator detachment.
You see,
first time the patient comes to me, I said to my assistant, probably you have taken the vision is not right. Let me take the vision, and then we send him for the OCT. But it was the same. So I'm done with my presentation. I can stop sharing.
Thank you, Anant. Thank you, Binde sir. Thank you, Bhumat sir. Binde sir and Bhumat sir, we ask all our faculty post our program that any suggestions that we can do better or any message for the PGs that how should they prepare on their exams and not only exam for whole of their 3-year post graduation. Any message from both of you, sir? Binde sir.
I think both of the students presented very well. Considering they are PGs, they have presented extremely well, and they should keep up the things. More than reading, I think they will learn more by presenting the cases. More than theory discussions and seminars, they will learn more and more helpful for the examination if they do more case presentations.
I agree with Dr. Sharad because hands-on experience, that is what eventually matters. They are going to read theory anyway, but I think spend a lot of time in a ward, see patients on your own, master your indirect ophthalmoscopy, not for VR, but for overall listening, because all these surgical techniques, everything, indirect ophthalmoscopy is still extremely important. Extreme periphery, you still can't see with your wide angle cameras. So spend enough time when you examine. Develop your own way. I mean, whatever you want, follow same pattern, right? Start from the lead, going up to the optic nerve and backward. So whatever way you want to do it, actually, the moment you develop that, unlikely you will miss any findings. No cutting corner, because the more you read, I mean, the more you examine the patient, you go through the history. Most important is let patient talk. They reveal their history. So many times we are in a hurry. And most important history part sometimes we can miss, which probably sometimes helps you to change the diagnosis. History is extremely important. And yes, why I want you to draw is not because we are old fashioned, because the more, so when you want, it is like a something you want to write. You read, you then you remember, and then you write, and again you forget, again you go back. So what happened? One time writing is equivalent to 3 times or 4 times reading. Similarly, when you want to draw a fundus, larger drawing particularly, so actually you are seeing that area 1, 2, 3, 4 times. So unlikely you will miss, and then when you develop that habit, unlikely you will miss the finding. And then once that is you are used to it, that it doesn't take much time really, because you develop once that pattern and habit. So please, yes, like a hands-on, spending time in awards for examining fundus, do all your duties and do diligently. Again, when you're doing duty, all the patients, and make sure that you see those patients, everything, and may take your notes, and then go back and read about it. So that is what long-term going to help in, because once you hands-on have this seeing a patient and experience those things, once you go read and you will not forget it, because rather than only theory, you mugging up. And when exam time comes, you really forget so many times, and you are particularly when you are tested. But once you are experienced things, I don't think you will forget it for the rest of your life.
Thank you, sir.
Other thing, what I feel is that the PG students should get more hands-on work. Like for every patient, they should have access to doing gonioscopy, applanation tonometry, indirect ophthalmoscopy, 90D lens. All these basic examination techniques, they should be allowed to do for most of the patients, at least the patients who are admitted in the ward. I remember, like, one of my colleagues in MBBS, she opted for diploma in ophthalmology in CMC Vellore. And Professor Ravi Thomas used to make the PG students do all the procedures, diagnostic procedures for each and every patient. Even if it is Calazion patient, you have to do slit lamp examination, you have to do applanation, you have to do 90D, you have to dilate the patient and do indirect ophthalmoscopy. So that kind of training, even though she did diploma in 2 years, she was so good. She was excellent. She was better than all our MS candidates. So I think basic examination techniques, if they do, they should become second nature to them. That is the greatest thing which they can do in the post graduation.
I think PGs are lucky enough today's scenario, because most of the institute have a infrastructure and they are allowed to use those equipment instruments. Okay. So previously we used to have a one slit lamp and one indirect ophthalmoscope and somebody, because if something goes wrong with that, then they have to raise indent, and again next 6 months, 1 year, it don't come back, and everybody suffers. So I think that will be a far better off. I think please use those equipment instruments what you have, like a opportunity to work on it now.
Very correct, sir. Shilpi ma'am?
Yes, sir.
Yeah, ma'am, you interact with many PGs, so any tips for them and anything for the program that can we do anything better than what we are doing presently? Any section can be added?
No, sir, the program is good. They should present, and this should is, I mean, I think. But for PGs, what sir has said, even if given the opportunity, many times they don't do the things. So if the facility is there and everything is there, they should also, if they show interest, now no one will stop them to do the things and learn the things. So that is one thing. Until and unless they do, they will not learn. You cannot learn just by seeing.
Dr. Shilpi, I would like to add on what you just now said. We also experience sometimes, ये मेरा काम नहीं है, ये मेरा duty नहीं है. I am not here. This is a clerical job. Nothing is clerical. The fact you are writing notes, you are writing admission orders, you are writing surgery notes, everything is learning. You don't realize that time, but once you finish your things and when you go out, then you'll realize how important those all things were. it sounds clerical, not, but to write that itself, you need to think about it, a systematic approach, chronologically, you put everything, writing medication a right way. That's a developing discipline for yourself. But because exactly what you said, Sriji, in your experience, I'm telling you, few of our ward nurses having a difficulty, like a duty doctor said, it's not my job, it's not my duty. Don't realize that they learn with that also. Please do not do that.
Very correct, sir. Purvasha ma'am. Purvasha ma'am.
Hi, good evening.
Hi, ma'am. Good evening, ma'am. Any you are training PGs at AIMS? Anything from your own fellowship, postgraduate days to today's fellows? Any tips from you that they should follow this?
So, a very good evening to everyone, and especially the senior sirs over here. And hi, Shilpi. Hi, Sumit. Um, yes, these days PGs are very well equipped. Also, they have started buying their own diagnostic equipment, as well as they are encouraged to utilize the department's instrumentation and equipment also. And with the fellowship trained consultants that we have, I think they have a very good exposure to a variety of subspecialties already. So I think they are in a good platform, and they just need to work hard and try and grasp as much as possible from each and every person that they can. So I think more enthusiasm on the part of postgraduates is needed, and they can just harness and tap that energy and the treasure that is available to them. So it's up to them to, you know, tap onto the treasure that they have. So that is what I would like to suggest.
Thank you so much, ma'am. So thank you, Dr. Prerna and Samarpita. Congratulations and very well presentation. Thank you, Dr. Anand. And of course, thanks a lot, Bhende sir, Bomat sir, for being here. And of course, Shilpi ma'am and Purvasha ma'am. I would like to thank on behalf of MOS team, and also thanks to Entod for providing this platform to all of us. Thank you all once again. We call it a night here.
Thank you very
Thank
much.
you, everybody.
Nice,
Good night.
nice seeing all of you.
Thank you.
Thank you.
Thank you, sir.
Bye bye.
Bye.
sir.
Good night, everybody.
Good night.
you.